All right, everyone. We are 1 minute past the hour. So in an effort for Caitlin and I to be on time for once, we'll actually go ahead and get started. Welcome to our webinar today. I'm Carrie Nixon, and this is Caitlin O'Connor. We are with Nixon Gwilt Law, and we are going to be talking with you about the proposed 2025 Medicare physician fee schedule. Particularly as it applies to healthcare innovators and digital health companies. So this year's Medicare physician fee schedule has some pretty interesting proposals in it. Past year or so, the last year, not a lot of new and exciting stuff. This year, definite change. Excuse me, with some introductions of some brand new code sets that really can make a very interesting difference in the way that care is delivered to patients. So we are excited to share those with you. Before we do so, let's take care of a couple of little housekeeping items. I think the next thing you're going to see is a lovely picture of Caitlin and myself, maybe. Is that right?
Yes.
There we go. This is us. If you haven't already, please connect with us on LinkedIn. And you also can join our newsletter. Click to sign up for our newsletter if you want to hear from us once a month. Next. Okay, so this one's kind of important. It's boring, but it's important. So Caitlin and I are both lawyers, but we are not your lawyers unless you have an engagement agreement with us. So what that means is, if today's webinar is really presented to be informational in a broad sense. It should not be considered legal advice that specifically applies to you and to your company, because as we all know, the devil is in the details with healthcare, and it's really important that we talk through implications for a particular company and what these new proposals mean for a particular company. And we, by the way, are happy to do that with you. And we've got a link here where if you are not currently a client and you want to talk with us, you can actually go to that link, nixongwiltlaw.com/get started, and you can sign up for a call with us.
Whoa.
There we go. All right. Here is what we are hoping you're going to get out of today's presentation. We're going to spend a good bit of time talking about two brand new code sets. The first is the Advanced Primary Care Management code set, and the second is the Digital Mental Health Treatment code set. We're going to talk about sort of how they're used, what they mean, and what their impact may be. Then towards the end, we're going to talk about a few more sort of other proposed changes that we think are going to be relevant, especially in the virtual care space, and we'll give you some highlights there as well. All right, I'm going to hand it over to Caitlin. Go for it.
Yes, I'm going to jump in. The other thing is we will do our best to leave time for questions at the end of the presentation. Usually we try to leave about 10 or 15 minutes, but you do have a Q&A function. So if you have questions, please feel free to drop them in there. Carrie and I are both monitoring them while we're presenting. So to the extent that we can, we'll work your questions into the presentation. And to the extent that we can't do that, we'll do our best to answer them at the end of the presentation.
Thank you, Caitlin. It was good to say that.
Yeah. No worries, no worries. Okay, let's just talk very briefly about where we are, why we are talking about the proposed Medicare physician fee schedule, and most importantly, what you all can do to make sure your voices are heard by CMS. So you may already know that in July, CMS published the proposed 2025 Medicare physician fee schedule. This happens every year, and it's my favorite time of year. This is the time of year where CMS is giving us a heads up as to what they intend to make rules for 2025 for reimbursement. This means that nothing we talk about today has been finalized yet, and it also means that we all have an opportunity to communicate directly with CMS to make sure that before they finalize these rules, they hopefully do so in a way that actually makes sense for patients and for businesses and providers alike. So right now we are in this public comment period. This means that right now through September 9th, we can submit comments to CMS on everything that they have proposed, and we can tell them what we think looks good, what we think doesn't look good, what the data says about how these services should work, anything that we've learned in implementing services that we're already implementing, and just make sure again that they've got a good sense of how this is actually working in practice. This is the one time a year that CMS is required to read our comments and respond to them. So they will read your comment if you submit one, and they will respond to your comment in the final rule. Carrie and I have been doing this with clients for years, and we have on several occasions had CMS respond directly to language that we've submitted, use language that we've submitted in the final rule. So this is a really good opportunity, again, to just make sure that your voice is heard, and most importantly, make sure that CMS is hearing from those of us that are actually providing these services every day. So that comment period ends September 9th. If you want to submit comments, you've got to submit them by September 9th. CMS will spend a couple of months reviewing all of the comments that they receive, putting together their thoughts on it, making any changes to what they've proposed. And then around November of this year, CMS will publish the 2025 final Medicare physician fee schedule. So that means that in November, usually mid to late November, we will know what the rules for reimbursement are going to look like beginning January 1st, 2025. So it will take a couple of months. It's a bit of a slow process, but like I said, this is a good opportunity for CMS to actually listen to you and respond to you. So it is worthwhile, and you'll have a little bit of a heads up before the final rule actually goes into effect in January. Without further ado, let's dive into what has been proposed thus far. The first category of codes that we are excited about, that I think will be a really big deal for a lot of our clients in the care management space, is this category of advanced primary care management services. There are 3 new codes proposed in this category, the first of which is what you see on your screen in front of you, GPCM1. GPCM1 is a code for providing advanced primary care management services to patients with 1 or fewer chronic conditions. These services can be provided by clinical staff, directed by a physician or other QHCP. And most importantly here, keep in mind for all of these GPCM services that the goal is for the practitioner that bills these codes to act as that continuing focal point for all needed healthcare services for a patient. We'll talk in a little more detail in a minute just about what we mean by advanced primary care management, what these services entail, and what the requirements will be. But what's interesting about this GPCM1 code is that it is for patients with 1 or fewer chronic conditions. If you are familiar with chronic care management, you know that chronic care management services are only available for patients with 2 or more diagnosed chronic conditions. So this particular code, GPCM1, opens up the door for reimbursement for providing the same level of care management services to those patients that only have 1 or fewer chronic conditions. So an additional opportunity for patients to get more comprehensive services from their provider, an additional opportunity for providers to get reimbursed for providing those services to patients, and an additional opportunity for vendors to provide additional support to their customer practices and bill them for it. So
And
that's GPCM1. Yeah, go ahead, Carrie.
Yeah, before we move on to the other codes, which are very related, I think it would be interesting to talk for a moment about sort of where these codes came from, right? Like so CMS, as many of you know, has an innovation center, and over the course of the past several years, really kind of since the Affordable Care Act passed in 2010, they have put forth a number of sort of innovation payment and delivery models to sort of test out. And CMS has done a number of sort of primary care focused innovation models. Some of you all may know of them. CPC Plus was one of them. CPC was another. Primary Care First, I think, was another. And these codes were the genesis, or maybe the codes were not the genesis. These innovation models were the genesis of these codes, right? These were sort of best practices that that CMS kind of gleaned and PCPs kind of gleaned from these innovation models. And my sense is that CMS is trying to facilitate more primary care physicians using these types of care management techniques in a fee-for-service realm, so that primary care physicians who are not used to sort of doing this more comprehensive care management and are not used to sort of a value-based care system can test them out in a fee-for-service construct and then move to a value-based realm. So I think it's a super interesting choice that I didn't necessarily expect for CMS to come out with this year, and really interesting potential, particularly since, as Caitlin's going to touch on, these codes do not rely on time-based. It's just get the stuff done in the way that it needs to be done. Over to you.
Exactly. Yeah. And I see someone asked in the Q&A what the difference is between APCM and PCM, and we're going to talk about that in a minute. It goes to a little bit of what Carrie just mentioned. So right, like Carrie said, CMS has already been offering these innovative payment models to a small number of practices on a test basis. They said, you know what, this is going pretty well. We actually think all patients should get access to this type of service. So here are the codes that we're going to allow you to bill for that. So we just talked about GPCM1. Let's talk about GPCM2. So GPCM2 is more similar to chronic care management in that it is advanced primary care management services for patients with multiple, that is 2 or more chronic conditions, expected to last at least 12 months or until the death of the patient. That definition, again, if you're familiar with CCM, that definition is pretty similar to how we define chronic condition for the purposes of CCM. Again, it can be provided by clinical staff under the direction of a physician or other QHCP. And again, this is a provider that is that continuing focal point for all of a patient's needed healthcare services. GPCM3 is very similar to GPCM2, but it's for qualified Medicare beneficiaries who have 2 or more chronic conditions. The important distinction here between GPCM3 and GPCM2 is that GPCM3 is provided to patients that are typically dual eligibles and maybe even a subset of dual eligible patients. That means they're eligible for Medicaid and Medicare, and that they likely don't have cost sharing requirements or their cost sharing requirements are covered. So where chronic care management and other care management services always require a copay, and copays we know can be barriers for patients, this code opens the door to provide these services to patients, again, without that barrier of a copay. What you might have noticed as I talked about GPCM 1, 2, and 3 is that these codes are sort of stratified based on risk. GPCM 1 is fairly low risk patients who have 1 or fewer chronic conditions. GPCM 2 is for patients that have 2 or more chronic conditions, but don't meet that qualified Medicare beneficiary definition. And then GPCM3 is for patients that do meet that qualified Medicare beneficiary definition. And the reason that GPCM3, as we'll see in a moment, is actually paid out higher than GPCM2 and why it's why it's stratified as a little bit higher risk patients than GPCM2 is because CMS is recognizing here the impact of social determinants of health, particularly on patients that are economically challenged. So again, these are primarily going to be dual eligible patients that are eligible and have both Medicaid and Medicare coverage, and they likely will not have to pay a copay if they receive these GPCM3 services. So that was kind of a high-level overview of the 3 codes. If you are familiar with CCM and other care management services, you might be thinking, what is the difference between these services and traditional CCM, or like someone already asked in the Q&A, what is the difference between these services and principal care management or PCM? And we're going to dig into that. So what you see on your screen right now is a very long list of 13 required service elements. One really important difference between APCM and traditional CCM and PCM is that it actually requires a little bit more than those codes typically require in terms of the elements that you have to offer and provide to patients. So I'm going to talk about each of these in a little bit more detail without taking up the entire hour that we have in front of us, because we have a lot more information to share with you. But one important note before I dig into the details is that you'll see at the top of the screen here, CMS is very clear in the proposed rule that not all of these service elements have to actually be provided to every single patient that you bill for each month. And in fact, CMS actually expects that in many cases, APCM will be billed for all of the patients in a practice's patient panel. So you'll have your patients that don't have 2 or more chronic conditions getting APCM1, GPCM1. You'll have those patients that maybe do have 2 or more chronic conditions getting PCM2, and then those higher risk qualified Medicare beneficiaries getting PCM3. And they will have access to all of these elements that I'm about to dig into, but they don't necessarily need all of them every single month. And that should be determined by the provider based on medical necessity. So just beginning, patient consent, this is fairly straightforward, like all care management services, and really most, if not all, healthcare services generally. Providers will have to collect informed consent from patients to make sure that patients understand what APCM is, what they have access to, and that they can only receive APCM from one practitioner per month. So they cannot receive APCM services from multiple practitioners, one practitioner per month. Again, you have to inform patients that cost sharing may apply, just like you do with other informed consent processes, and you have to document that consent in the medical record. You do not have to obtain this consent in writing, but you do have to document it in the medical record. The second element up here is the initiating visit. The initiating visit requirement is the initiating visit is required for new patients or patients not seen within the last 3 years by a practice. So for established patients that are already meeting with their providers regularly, those patients may not require an initiating visit. You still have to collect informed consent. So you still have to talk to them and explain to them what APCM is, but you don't necessarily need to have a separate initiating visit with those patients. But for new patients and patients not seen within 3 years, you do have to have that initiating visit, which can be done via telehealth. The third element here, you have to offer 24/7 access to the care team. This is very common. This is already a requirement for CCM and PCM. So if you are already providing CCM and or PCM, you probably already know about this requirement. Important note here, this does not mean that you have to have one staff member that is awake 24/7 and taking phone calls from patients, but you do have to have a call center or somewhere that patients can call and contact someone on the care team that will then communicate that conversation back to the provider, the designated care team member, whoever it needs to be communicated back to. So someone has to be available 24/7. A lot of our clients utilize outsourced call centers for that night and weekend access. That's perfectly fine. The next element, continuity of care. This is a big one. This is one of the things that CMS has kind of been talking about for a couple of years, making sure that patients have access to a designated member of their care team. So they have one person that they can call up on a regular basis, that they're checking in with on a regular basis, and that they can schedule successive routine appointments with. That can be an RN, that can be the physician. It doesn't have to be the billing provider, but it can be. Or it can be an RN, but it does have to be a designated member of the care team, someone for the patient and their caretakers to be familiar with and to communicate with on an ongoing basis. You also have to, practices also have to make available alternative care settings. So one of the things that CMS and we all have learned in the last couple of years, particularly during COVID, is that traditional office visits aren't always the most valuable way to treat patients. So as part of APCM, providers will need to make available other care settings than the traditional office visit. That might include home visits, that might include telehealth visits, that might include expanded hours in person so that people don't have to take off work to come into the office, but you have to offer those alternative care settings to patients who need them. Providers also will need to offer comprehensive care management, which involves a systematic needs assessment, which involves system-based approaches to preventive services, and likely also involves medication reconciliation, particularly for those patients that have 2 or more chronic conditions. A lot of times they are taking multiple medications to manage their conditions and the symptoms they experience from those conditions. And part of chronic care management has always been conducting a medication reconciliation. That's going to carry through to these APCM services as well, to make sure the patients aren't taking anything that aren't taking medications that have bad interactions with one another, or multiple medications for the same condition, making sure that you're checking in with the patient on that on an ongoing basis. Similar to CCM, you have to provide an electronic care plan. Essentially, you have to make sure that the care plan for APCM is not only available internally to the care team, but is also electronically available to the patient. That is typically done through a patient portal into the EHR. Sometimes it is done through a separate app, but most importantly, the care plan does have to be available to the patient. You also, or practices will also have to support coordination of care transitions. This is making sure that patients who are, in the emergency room for a couple of days, or in a hospital stay for a couple of days, or a skilled nursing facility, have that support from their primary care team as they transition back out of those inpatient settings, back into inpatient settings, to make sure that anything they learn, any changes to their care plan, anything they learned while they were in the inpatient setting carries through into that outpatient setting, and that they have that ongoing support. This also includes timely follow-up communication. So after discharge, the care team does need to check in with the patient within 7 calendar days, or as otherwise clinically indicated. If it needs to be done sooner, it needs to be done sooner. If it can be done later, that's okay too. But for the most part, it has to be done within 7 calendar days of discharge. The care team also has to offer ongoing communication to the patient. This includes coordinating communication and needed services from other practitioners, such as home and community-based service providers, community-based social service providers. That's going to be really important for those qualified Medicare beneficiaries who have who are experiencing social determinants of health that may be negatively impacting their care, and other types of community available resources for them, nursing facilities, other healthcare facilities, etc. Enhanced communication methods. This is not just your audio phone call between the care team and the patient, but also offering asynchronous communication methods. I think someone asked in the Q&A a little while ago about communication methods that are required. The good news for APCM is that it can be asynchronous or it can be synchronous. And in fact, you have to offer both. So you have to offer some sort of enhanced communication method, whether that is chat within the EHR or a separate application, whether that is telehealth visits, whether that is email, some way to maintain that ongoing communication with the patient, which again can be synchronous or asynchronous. All right, population data analysis. This is a lot of information. I'm sure everyone has questions, and I'm kind of rushing through it so that Carrie can tell you all about the digital mental health treatment codes. But again, just feel free to ask questions as we go through. All right, let's look at these last 3 elements here. Population data analysis. One of the important aspects of APCM that is not required currently for CCM or PCM is that providers will have to conduct ongoing analysis of their patient population. And they have to use that data to identify gaps in care, offer additional interventions as appropriate, and make sure the patient is actually receiving all of the care that they need. This, I think, is one area where, and we'll talk about the next 2, which I think also are going to carry through here. This is one area of APCM where I think our software vendor clients can be really valuable. Some of you that are developing new AI algorithms, or maybe even on that enhanced communication method, developing some sort of LLM. This is one area where I think those technology vendors are going to be able to add a lot of value to practices. You already have the data. You already have the ability to analyze that data. You are going to be in a great position to help providers identify gaps gaps in care, offer additional interventions, understand the data. And this is actually something with remote monitoring that we talk about a lot, right? Providers have access to tons of data. What they don't always have is good insight into that data and what it means. This ongoing analysis will help with that as well. And that will also play into this next element here, which is risk stratification. So one thing that providers will need to be continuing to do is stratifying their patients based on risk. And that risk will be based on defined diagnoses, claims, or other electronic data. It's actually quite flexible, really probably will vary a little bit by population and by condition. But again, to the extent that the technology vendors have data and have algorithms to analyze that data and provide these insights, that will be a really great way for you to add value for providers that want to utilize these APCM codes. And then lastly, performance measurement. As we talked about at the outset of this section of the presentation, we talked about value-based innovation models that CMS has been testing out over the last couple of years. One of the things that is very important in value-based arrangements, but has not so much been integrated into fee-for-service, is performance measurement, making sure that you are setting goals to improve the quality of care, reduce the total cost of care, and use meaningful technology to provide services to patients. Setting those goals and then monitoring them and making sure you're actually achieving them. So monitoring your performance on an ongoing basis. If you're the technology vendor, monitoring the provider's performance on an ongoing basis, monitoring the value of the service to make sure, again, that it is adding value for patients. So like Carrie mentioned a few minutes ago, this is another way that CMS is starting to bridge that gap between fee-for-service billing and care delivery into value-based care delivery, where now we have a fee-for-service model, a fee-for-service billing model that also starts to bring in some of those value-based elements. So again, that's a lot of information. There are 13 elements that are required. Just remember that not all of those elements are required to be provided to every single patient every single month. They just have to be available.
And Caitlin, I'm going to give you a breather for a second,
Yeah.
because this is a lot. Like I'll say, when I first saw these 13 service elements requirements, I was like, whoa, this could potentially be a really heavy lift for practices. Fortunately, a lot of the elements are already being done, or platforms that facilitate CCM and PCM or other care management services should be able to relatively easily maybe incorporate some of these other aspects. But sort of the question in my mind was, what's the reimbursement going to look like, to cover sort of these holistic services? And that was sort of the kicker for me. So Caitlin, I think the next slide gives us a peek at that. Is that right?
Well, the next slide is just some key takeaways.
Oh, the key takeaways. Okay.
Yeah.
Yeah.
And is that cutting off on everyone's screen at the bottom there?
Sorry, say that again.
Is the image cutting off at the bottom? I don't know why it's doing that.
It does seem to be cutting off at the bottom. I don't know why.
Well, I will tell you all what it says. Don't worry.
That is strange.
All right, so do you want me to go through the key takeaways, Carrie, before we go to the value? Okay, let's talk about some key takeaways, because again, that was a lot of information. We want to make sure that you all have exactly what's most important as something to take away from this presentation. So physicians and non-physician practitioners can order and bill APCM services. That includes nurse practitioners, physician assistants, certified nurse midwives, and certified nurse specialists, I want to say is what CNS stands for. Anyway, these are the same providers that can order and bill for RPM, for CCM, for PCM, for other types of evaluation and management services. However, only one practitioner per patient per month can bill these services. So really important takeaway that Carrie and I were just chatting about before this presentation is that there are some services that cannot be billed concurrently with APCM. Those are listed here. Those are CCM, complex CCM, and PCM. However, this rule, only one practitioner per patient per month, only applies within that provider's practice. So one practitioner per patient per month, but practitioners outside of the primary care practice can bill other care management services. They can bill CCM, they can bill complex CCM, they can bill PCM. So again, one practitioner per patient per month can provide these care management services within their practice, but practices outside of that primary care practice can still provide care management services and get reimbursed for them. That is a really important takeaway that we've talked to a couple of clients about. APCM is a designated care management service, which means that the clinical staff or auxiliary personnel can be supervised via general supervision or remotely, lends itself very well to an outsourced care team, just like CCM, RPM, and PCM. APCM services are not time-based. So this is also a really important takeaway. We talk with clients all the time who tell us, hey, we have these patients that are on CCM or PCM or RPM, and they just don't require 30 minutes of time, or they just don't require 20 minutes of time in a month to keep them healthy. The great thing about these APCM codes is CMS is intentionally capturing those patients that don't require the full 20 minutes or the full 30 minutes of time in a month. So you don't have to track time. You do not have to, have a time tracker going. You don't have to enter any time you don't have to enter any time entries into the medical record. You just have to document that the elements we just discussed are available to all patients that are receiving these APCM services. Think about GPCM1. That's a code for patients that have one or fewer chronic conditions. It may be the case that those patients only need a couple of minutes of check-in every month, maybe a couple of messages back and forth, maybe a short look at some of the data in the care plan to make sure that they're still receiving the services they need, or to make sure they're getting, appointments scheduled when they need to. But you can still bill for those patients, even if you only spend 5 minutes providing the services to them. And again, like we said at the beginning, CMS specifically says they actually expect APCM to be billed for all of the patients within a practice. So they're not time-based. You don't have to worry about time tracking. That is a big barrier for some of our clients that do other care management services. And I think that's a really big win for those of us in this space. And then lastly, I apologize that part of the slide is cut off. And I mentioned this on the last slide as well, but one sort of takeaway around APCM is that it opens the door for the use of AI technologies to automate some of these functions. So to automate that population data analysis, automate that risk stratification, automate that performance measurement. So you're taking that burden off of the provider, but still adding that value to make sure that those elements are in place. Carrie, any other key takeaways before we look at the valuation really quickly?
No, I don't think so. I'm interested to hear people's reactions to the valuations. I'll tell y'all that my initial reaction was, I don't know, but go ahead and put them up, Caitlin, and we'll talk about them.
Awesome. All right, so GPCM1, the code for patients with one or fewer chronic conditions, is proposed to be valued at $10 per patient per month. That is quite low. If you compare that with CCM or PCM, it's actually like 20%, if that, of what those codes are typically reimbursed, maybe even less. So it's very low. Balance that with the fact that there are no time requirements. It may be worth it for some patients, but it may not be for others. So if you are thinking about submitting comments, you should think about commenting. You should think about whether or not this amount is appropriate. And if you are thinking this amount is not appropriate, you should be thinking about submitting comments. GPCM2, the valuation proposed for that one is $50 per patient per month. This is the code for patients with 2 or more chronic conditions that do not meet that qualified Medicare beneficiary definition. And then GPCM3 is valued at, or proposed to be valued at, $110 per patient per month. Again, those are the GPCM3 is those patients that have 2 or more chronic conditions and are qualified Medicare beneficiaries. So yeah, when you compare these amounts to CCM and PCM, they're quite a bit lower. And I think that has definitely been a concern for many of our clients and for us as well. One thing that, when you submit comments to CMS, one thing that can be really valuable is showing data that you have that actually shows them what the cost of these kinds of services are. And maybe reminding them that if this is intended to be a value-based service, it doesn't necessarily only need to be based on cost, and that perhaps they should think about the additional value that is available to patients. So think about those valuation amounts. They are, again, quite low. And if you have questions about it, let us know. Like Carrie said, we're interested to hear your reactions.
Yeah, please drop them in the Q&A if you have some reactions. I'm just interested. My initial sense was like $10 a month. Holy cow, that's really, really low. But if you consider that, like, they literally do say it is possible that a practice could bill this for every one of these codes for every patient, that's kind of a big deal, right? And $10 a month is better than $0 a month for services that are, care coordination and care management services that are being provided. When you consider that it looks like patients are going to have to pay a 20% copay or a general copay on that $10 a month, that's a tricky thing. So, that's something to consider. But the other thing to keep in mind, right, is that if a practice is already doing CCM, in particular, or maybe they're doing PCM, but usually with a primary care practice, it would be CCM, then, if they meet the 20-minute time requirement for CCM, they can bill CCM. They would just have to choose, right? This is an option for if you're doing CCM and you don't meet that 20-minute requirement, you have an alternative to actually bill something for the work that you have done for those patients.
Yeah, and just a quick note, because someone just asked about it in the Q&A. These amounts are the proposed national payment amounts. These amounts will vary a little bit by geography, but for the most part, they won't vary by too much, most likely. All right, Carrie, you ready to talk about digital mental health treatment?
Yep, I'll leave it to you to take on some of those open questions, and we'll move to DMHT.
Perfect.
Okay, digital mental health treatment codes. These are brand new. They are a result of feedback that CMS received in response to its request for information that was in either last year's, I think it was last year's final rule, possibly the year before's final rule. But CMS did specifically ask for information about how digital therapeutics and digital health interventions were being used and how they were being paid for. And groups like the American Telemedicine Association and the Digital Therapeutics Alliance and all kinds of other stakeholders submitted comments and information as requested. And I was very, very glad to see that that one result as a first step were these digital mental health treatment codes. So they're referred to as DMHT. It is a set of 3 codes. I'll just say, sort of as a framing issue, these codes are widely considered to be a very positive first step towards reimbursement of other types of digital therapeutics as well. So many of you know that we have remote physiologic monitoring and remote therapeutic monitoring code sets. There are digital therapeutic interventions or digital health interventions that don't involve just monitoring. They actually they have therapeutic uses for a patient rather than simply sort of monitoring uses. And so the RPM or RTM codes don't necessarily always fully fit with digital health platforms that are just based on monitoring. And so the result, right, was these codes, the creation starting in the mental health space, as we do so frequently, creation of codes that are payable, where there is a treatment happening, right, an actual treatment happening, an intervention happening. Could also involve monitoring, nothing to prevent it from involving monitoring, but is a broader use of a digital intervention. So these DMHT codes are actually sort of modeled on the remote therapeutic monitoring code sets and RPM code sets, in that there is a supply of device code, which is this GMBT1. That is for the supply of a digital mental health treatment device, meaning generally a platform, right? A software platform like an app or a patient portal. Also includes education and onboarding. If you want to think of the analogy to RPM or RTM, it's the education and setup is one code, the supply of device is another code. Here they're combining those two codes. The tricky thing is that the device is CMS as written is requiring the device to be FDA cleared. Now, there are a couple of trains of thought on that. One is that CMS is CMS, they're not FDA. They're not familiar with some of the terminology that FDA uses when they're talking about devices. Lots of people use FDA device, FDA cleared device, FDA approved device interchangeably. Those are actually potentially three different things. They have three different meanings. And so by requiring that the digital mental health treatment device be FDA cleared in order to be reimbursed, CMS, I believe inadvertently, is cutting out mental health treatment devices, digital health mental treatment devices that would otherwise be required to follow a FDA approval pathway through de novo review, through PMA review. It also would not include devices that have been designated as FDA, 510K exempt. So I don't think that was CMS's intention. We could go into sort of a long and detailed discussion about FDA regulatory pathways. But the bottom line here is that in this case, if this particular code is passed with just the FDA cleared language, we're I think it's going to be inadvertently leaving out a number of digital health mental treatment devices that would otherwise be used. So not only devices that would go through a different FDA pathway, but also devices that are limited to particular uses. Substance use disorder and sleep therapy issues in particular were listed. So we didn't include it here, but in the regulation, CMS, in the proposed rule, CMS cites a particular regulation. That regulation is sort of limited to those mental health treatment use cases. Again, I don't think that was actually CMS's intent, but if we don't comment and sort of move to fix that, we're going to be not only limited to the types of devices, we're going to be limited to the types of use cases, mental health treatment use cases that these devices are intended for. So all that to say, this is like a great first step. We just need to work with CMS a little bit to be sure that they're not using FDA terminology in a way that sort of inadvertently leaves out a lot of use cases. So we hit the first bullet pretty clearly there. Again, similarly to RPM or RTM, the billing practitioner would be supplying the device, incurring the cost of furnishing the device. This is very similar to how it works in RPM and RTM. The device, can be furnished incident to a practitioner's services, and the billing practitioner has to order or prescribe the use of that device for treatment. Let's go to the next slide. Okay, so here's the analogy to the treatment management services and monitoring services associated with RPM and RTM. For GMBT2, the other new code, the first 20 minutes of the treatment management services that are related to the therapy, the digital mental health therapy, are reimbursable, right? So first 20 minutes of services requiring, similar to RPM and RTM, at least one interactive communication with the patient. And that generally means, according to CMS, at least it did in RPM and RTM context, live synchronous. This, if that first 20 minutes that occurs during a calendar month is going to have a level of reimbursement. Similarly, next slide, we have an add-on code like we do for RPM or RTM, which is for each additional 20 minutes of monthly treatment management services, again, requiring at least one interactive communication with the patient during the calendar month. So we also have not seen a limitation on the number of add-ons that you could use with the DMHT codes. But I'll note that some of the MACs in, sort of commenting on the add-on code for RPM and RTM have said, we wouldn't expect to see more than 1 or 2 add-on codes. We don't know whether that's going to hold true with these digital mental health treatment codes. It may be worth commenting to CMS that given that these, these devices will also be used like as part of therapy itself, perhaps it's appropriate to allow, a higher number of add-on codes for each 20 minutes. If you have a 20-minute session, with someone, you could do that several times a month. So that's something to consider when thinking about comments to these codes. Let's go to the next slide. Okay, so so I mentioned that one really important comment to make is about FDA cleared devices and what types of devices can be used. The second really important thing that we need to figure out is the pricing for the supply of device code. So CMS sort of punted on this. They said, we want to hear from you about how to think about pricing these digital mental health treatment supply of device codes. So if you are a developer of a digital mental health platform, CMS wants to hear from you and understand all the expense that goes into developing that platform and how we might think about pricing it. So you all who are familiar with the remote physiologic monitoring space may recall that there is just one price for supply of a device, an RPM device, right? So a wireless blood pressure cuff is going to be reimbursed at the same amount as maybe a much more complicated device that is measuring a much more targeted and specialized metric, right? So doesn't really matter. You're going to get the same amount no matter what the device costs. People don't love that, and CMS kind of wants to avoid that with these DMHT devices. And so it's asking for input from industry on sort of how can we think about pricing these things. I will tell you that both the American Telemedicine Association and the Digital Therapeutics Alliance are thinking long and hard about this question because it's really important. What we want to do is not make it so complicated so as to discourage CMS from finalizing this code set, but also make it such that digital health platforms are being adequately priced. It is the case that sometimes CMS has taken the view that, oh, it's just a software, like it's not a hardware thing. It doesn't cost that much. It really doesn't cost anything. And as anyone knows who has developed a software platform, that is not the case. And again, so the services aspects of the codes, GMBT2 and GMBT3, are actually going to be crosswalked to the remote therapeutic monitoring codes, the services components there, which I think we're at about 48, something like that, dollars per month per 20 minutes. Caitlin, does that sound about right? Something like that. It obviously depends on your particular geography. But that's the reimbursement amount there. Okay, let's move on to the next slide. So our key takeaways on these codes, great first step, right? I think we should really applaud and encourage CMS on creating these codes out of whole cloth. Oftentimes they will wait from the AMA CPT committee to put forward codes and have them reimbursed. They did this on their own this time, and I think that's great. That's a real step towards fostering innovation. The second component is we've really got to focus on how to appropriately price the supply of the device. And the third, as I said, is we got to kind of fix these this FDA cleared language to make it more accessible and user friendly for people. All right. Let's see. Caitlin, you want to take this one or you want me to?
Yeah, sure. I can take this one.
Okay.
And I'm just going to do this quickly so that we can leave some time for questions. We have a couple of good questions in the chat, Carrie, that I thought might be good to just talk about if we have time. So billing for care management services and FQHCs and RHCs. Really quickly, if you're familiar with FQHCs and RHCs, for the last several years, they've been billing G0511 for all care management services that they provide to patients. That includes CCM, PCM, BHI, TCM, the list goes on. As of last year, it also includes, or really as of this year, 2024, it also includes RPM and RTM. What CMS learned very quickly, and what we kind of predicted would be the case, is that it became very hard to track what services were actually being provided and when and how many times to bill G0511. When CMS added RPM and RTM into G0511, they also said, don't worry, you can bill G0511 multiple times for different services that you provide. So you can bill it for CCM, and you can bill it for RPM, and you can bill it for RTM. They learned that this was administratively burdensome for everyone, even though the intention was to streamline things. And they got a bunch of feedback from FQHCs and RHCs. So what they proposed is to do away with G0511 altogether and just require FQHCs and RHCs to individually bill care management services as appropriate, care management CPT codes as appropriate. And that would include those APCM codes that I talked about at the beginning. So this is a fairly straightforward proposal. I actually think it's great. We know that this is important for a lot of our clients that work with FQHCs and RHCs. I think it will open the door for additional services to be provided to those patients that they really need.
Yeah, this one was causing a ton of confusion last year. Yeah. No one knew what to do with it.
Yeah, exactly. Do you want to talk about direct supervision, Carrie?
Sure. Okay, so many of you know that services provided by clinical staff that or auxiliary staff that can be billed incident to a practitioner's services have typically required, unless otherwise accepted, direct supervision by the practitioner. And that means that the clinical staff member needs to be physically located in the same building or office suite as the billing practitioner when providing those services. This was not possible during COVID in many cases, and so direct supervision of clinical staff or auxiliary staff was allowed to happen through virtual audio-visual or virtual means. And lo and behold, everyone found out that that worked pretty well. So we now have a definition of direct supervision that that includes, the availability of the supervising practitioner, the billing practitioner, by audiovisual technology, and again, not super specified there. Rather than having the auxiliary staff be located in the same space as the supervising or billing practitioner. This is an extension this is a rule that had been extended several times after COVID, and we are now moving towards changing the actual definition of direct supervision and just making the definition encompass audio video availability. So that's really great news for any kind of incident to billable services that may lend themselves to being done in a virtual manner.
Yeah, that's a really good one as well.
Yeah.
And then lastly, really quick, PTAs and OTAs have traditionally always required direct supervision by physical therapists and occupational therapists, respectively. CMS is proposing to allow general supervision for all PTA and OTA services. So even those services that are not designated care management services, if this proposal is finalized, will now be able to be provided with remote supervision of those PTAs and OTAs. Again, just really important for expanding access to physical therapy and occupational therapy services, particularly virtual ones. So that's all we have substantively. We would love for you to submit comments to CMS. Like we said, this is a really important time of year, the only time of year that CMS is actually required to read and respond to your comments. And if you would like our help, please let us know. We're happy to help you with those comments. We've got 4 minutes left. Carrie, there are a couple of questions in the Q&A that I thought we might be able to address live.
Yep, sure. And I'm finishing typing one, but go ahead and read a couple out and we'll go from there.
Okay, perfect. So the one that you're typing in an answer for, I actually thought would be interesting to talk about.
Yes.
So anonymous attendee, thank you for being here, anonymous attendee. So it sounds like we can bounce between CCM and APCM for a given patient month to month, depending on whether or not we meet the CCM requirements. Do we need informed consent separately for the two different services? And if so, can we obtain them simultaneously? Do you want to answer that one, Carrie?
Yeah. So look, does CMS answer this specific question in there? No, in the rule, no. But so my take is yes, I think you're right. You can it appears that the purpose of these APCM codes is to allow you to sort of bounce back and forth with a patient from month to month, depending on sort of what services have been provided and whether time requirements have been met. You do need to get informed consent for each service. There's nothing that says you could not do so simultaneously for both services, have one consent describing both services and getting consent at the time for both of those services. No reason not to do that. And I think in fact that makes a lot of sense.
Yeah, 100%. That was my thought too. Okay, since there's a treatment requirement for the DMHT codes, is there more liability for the provider? I think this is an interesting one. Clients ask us about this quite a bit, whether or not, adding technology, adding data creates more liability for providers. From my perspective, it doesn't. I think as long as you clearly communicate with the patient what they're getting and what it all means, and you provide them adequate assistance in use of the technology, I don't think it adds liability for the provider. I do think that because that treatment language is included in there, that's how the FDA requirements get tied in, and it changes the type of FDA approval or clearance or registration that you might need. So I think it's actually more liability for the software vendor, the software manufacturer, the developer, but not necessarily for the provider. I don't know, Carrie, if you have a different thought on that.
Yeah, I mean, I agree that this is where FDA comes in, right? I mean, FDA is charged with protecting patient safety, right? And when they look at a device, they are looking specifically to see what type of risk or what level of risk it poses to patients. And, a device has to go through an FDA process in order to get to market, to be in market in a compliant manner in the US. Unless it's subject to enforcement discretion, in which case it's deemed low enough risk to patient safety that FDA has said they don't need to regulate it. So to Caitlin's point, I think, that's kind of where the liability lays. And, the goal is, right, for practitioners to be able to rely on the fact that the device has gone through that FDA process as appropriate and if appropriate. So they can take some comfort in that.
Yeah, exactly. I think that's exactly what they were thinking about when they made that rule. And yeah, we'll see how that plays out. All right, it's exactly 3 o'clock Eastern time, 12 p.m. for our Pacific attendees. Thank you all for being here. This recording will be available very shortly. You will get it directly to your inbox, and then it will be posted on our website. So please don't hesitate to follow up if you have additional questions. We did our best to answer you all, but there are always some lingering questions that we don't get to. So we appreciate you all being here, and thank you so much.
Yeah, thank you, Daniel, Marlo, Christine, Nick, all of you with your kind
Yeah.
words. We're glad you found it informative. Have a good one, y'all.